Hello.
Hello.
Hello, good morning, sir.
Yeah, good morning. We can start if everyone is there.
Sir, only two people has come.
Okay, we'll start in 2 minutes. Okay.
Okay, sir. Hello. Hello. Hello, sir.
Yeah, okay, we can start.
Okay, sir. So, good morning, everyone. Today we are discussing complicated cataract. Starting with the introduction, it is the opacification of crystalline lens secondary to intraocular disease, most commonly the inflammatory condition that is uveitis. But some other intraocular disease have also been identified that cause a similar cataract, that is degenerative condition. For example, essential iris atrophy, retinitis pigmentosa, myopic chorioretinal degeneration, some intraocular tumors like retinoblastoma, melanoma, metastatic tumor involving the choroid, long-standing retinal detachments, and primary and secondary glaucoma. However, cataract being the most common complication of chronic or recurrent uveitis with incidence of 57 to 78%. So the term complicated cataract has been reserved for the post-uveitic cataract till now. Now, the both intraocular inflammation and the corticosteroid that is used to control this inflammation both combinedly lead to the cataract progression in these uveitic patients. So what happened in these patients? The inflammatory condition leads to the diffusion of toxin in intraocular fluid, and since lens being the avascular structure driving its nutrition from intraocular fluid, so these toxin enter in the lens and causes rearrangement of lens metabolism. Now, when we see the patient of this uveitic cataract, most commonly we see posterior subcapsular cataract. This is because the posterior capsule of the lens is thin and lack epithelial support and toxin. So the toxin diffuse posteriorly, leading to the development of opacification posteriorly. And these opacity is irregular in outline, appearing as a breadcrumb in the slit lamp. Now, what are the indication of doing cataract surgery in these uveitic patients? If the visual acuity is decreased, explained by cataract alone, if there is inability to examine the posterior segment in potentially progressive posterior segment disease, if lens itself causing the uveitis, that is phacoantigenic uveitis, or in pediatric patient with the potential for amblyopia development. Now, what are the contraindication for the cataract surgery? If the patient has active anterior segment inflammation, surgery is contraindicated. It is recommended to have 3-month period of questions before the cataract surgery. Then, if the patient have active surface infection like corneal ulcer or bacterial keratitis, then also the cataract surgery shouldn't be done. Then, other than that, there is one relative contraindication, that when a concurrent ocular pathology that is likely to prevent the visual improvement even after successful cataract surgery, if it does happen, then also we shouldn't do the cataract surgery. In these cases, the cataract surgery should be done only when we need to see the fundus for the disease progression. So preoperative assessment, preoperatively, we have to confirm that the loss of vision is due to the lens opacity. If there is non-lenticular comorbidities like severe CME, severe glaucomatous cupping, corneal opacity, vitreous haze, etc., along with this cataract opacity, then obviously it will cause the poor visual outcome after the surgery. So proper preoperative assessment, including the ocular and systemic history and examination, is carried out. Like we have to carry out the macular function test like potential acuity meter, laser interferometry to help predict the visual outcome. Then OCT evaluation of nerve fiber layer and visual field testing for glaucomatous optic neuropathy. Then OCT evaluation of macula to assess the thickness of macula, presence of any ERM or CME. Then angiography in case of posterior or pen uveitis or retinal vasculitis. Then specular microscopy, because the eyes with uveitis have lower central endothelial cell density and increased central corneal thickness, and corneal edema may not be apparent on examination. Then B-scan ultrasound to look for the status of retina in case of total opacification of lens, to rule out any choroidal effusion and identify any intraocular tumor. Now, as we know, these post-uveitic cataract patient have a poor prognosis as compared to non-uveitic patient. So also in a multi-center uveitis steroid treatment trial, that is MUST trial, it has been noted that only 62% of patients who undergo cataract surgery achieve vision of 20/40 or better. So we have to counsel the patient about this possible limited prognosis. We have to counsel them for prolonged follow-up and increased need for medication in the perioperative period. Then there can be increased likelihood of additional procedures like glaucoma surgeries or NDI. Then we have also counseled them about the risk of complications that we discuss later. Then IOL implantation in uveitis, as IOL implantation can initiate the foreign body reaction and trigger the complement pathway that result into the adhesion on the lens, anterior capsule phimosis, and posterior capsule opacity. But it has been noted that if there is good preoperative control of inflammation, this IOL can be placed safely in most patients. So the hydrophilic monofocal acrylic posterior chamber lens implantation is preferred, as it reduces the adhesion of inflammatory cell to the IOL surface, and implantation of this IOL in children with juvenile idiopathic arthritis is controversial, as in these there is poorly control of inflammation and IOL implantation acting as foreign body, and it further increase this inflammation. Then in this uveitic patient, the mainstay is to control the pre and post operative inflammation, and also to control the CME, to prevent the CME post operatively. So for that we have to prescribe the corticosteroid. It has been noted that perioperative oral steroid have been shown to reduce the risk for post operative CME by 80%. So perioperative steroid prophylaxis, oral prednisolone 1 milligram per kg per day, maximum 6 milligram per day, along with the topical prednisolone acetate 1% eye drop 8 times a day, starting 2 days before the day of surgery, and tapering over 7 to 14 days has been recommended by Foster. Then if the uveitis is infectious, that is due to herpes simplex or ocular toxoplasmosis, you also have to add the antimicrobial drug starting 2 days before surgery until 2 to 3 weeks post operatively at full dose, and then on maintenance dose for weeks to months. Like for example, acyclovir 400 mg 5 times daily, and then the 400 mg twice daily is the maintenance dose. Valacyclovir 1 gram orally twice daily, then 500 mg per day is the maintenance dose. Then immunosuppressive agents can also be added, like azathioprine 1 to 2 milligram per kg, started 2 weeks before surgery. If patients are currently being treated with immunosuppressive agents like in juvenile idiopathic arthritis or Behçet's disease, there is no need to discontinue before cataract surgery. But if patients are not an immunosuppressive agent, consider to start in condition like poorly controlled diabetes, hypertension, or other systemic disease that likely to exacerbate by systemic steroid therapy, or if the ocular inflammation could not control on steroid therapy. Now, the surgical procedure, first anesthesia, peribulbar block should be considered to avoid pain during iris manipulation, as local anesthesia may not be effective on inflamed tissue. Then surgical incision, clear corneal incision is preferred to prevent the iris prolapse and to preserve the conjunctiva for future glaucoma procedures. As if the patient have cataract with the glaucoma, it is advisable not to do both the surgeries at one time, but to keep the gap of 1 month between the two surgeries. Then capsular hexes should be of appropriate diameter, that is 5 to 6 mm. Large diameter has risk of IOL decentration, and small diameter associated with phimosis and anterior synecdoche. Then cataract extraction by phacoemulsification and in the bag IOL implantation is preferred. Now, intraoperative medical management, patient that is pre-treated with oral prednisolone should be given intravenous corticosteroid in the form of methyl prednisolone 62.5 to 125 milligram intraoperatively, or we can give the intracameral triamcinolone 1 to 2 milligram, or we can give the intravitreal triamcinolone 4 mg. Now, the factors which complicate this cataract surgery in uveitis patient, first is these patients have poor pupillary dilatation. How to manage it? So we have to we can put the intracameral adrenaline, or by the heavy dispersive OVDs, or by placing iris hook or expander ring. Or then these patients can have peripheral anterior synecdoche or posterior synecdoche that can be released using the viscodissection. As you can see, this patient is having the posterior synecdoche and the anterior synecdoche. Now, as you can see, when surgeon is injecting the dye and air, there is barely any space left. It means there is also the shallowing of anterior chamber, probably due to the anterior synecdoche. Now, you can see surgeon is trying to break the synecdoche and put the dye below the iris. This is because so after pupillary dilatation, we can have properly stained capsule. Then, as you can see now, surgeon is injecting the heavy dispersive OVDs like Hylocoat or Viscoat, and along with it, he is breaking the synecdoche, the anterior synecdoche, by the swiping motion. Now, after this OVD, surgeon is using the Sinski to break the posterior synecdoche. And as you can see, the pupil is not dilated. So now surgeon is planning to put the B-hex ring to dilate this small pupil. So this patient doesn't have, pupillary membrane can also occur in these patients. And if it is there, you have to divide it by Vanage scissors. Then a patient can also have calcific band keratopathy, as you can see in the first picture. And obviously, they can affect the vision during the cataract surgery. So first you have to treat it by chelation with EDTA, and then when it got healed, then you can perform the cataract surgery. Then shallow anterior chamber, as we can see as we saw in the video, we will manage it by putting the heavy dispersive OVDs. Then patient can have the jonular weakness, and it can be treated by placing the CTR or capsular hook. Then intraoperative complication, there can be retained lens or nuclear fragments if it is due to the compromised visibility, and it can cause severe postoperative inflammation. Then if you doesn't put CTR in in the zonular weak cases, then zonulolysis can occur. Then posterior capsule rent can occur, which cause significant post-operative inflammation. And in this case, anterior vitrectomy should perform and IOL is implanted depending upon the capsule status. Like if the PCR is small, if the rent is small, then you can put it in the bag only. If it is large and capsule is well maintained, then you can put in the sulcus. Then post-operative complication, first and the most important is cystoid macular edema. It is most common pre and post-operative complication, and strict steroid use can prevent and treat this. Then intraocular pressure abnormalities like IOP may raise it due to compromised trabecular meshwork, and it is managed by anti-glaucoma medication, and may be low due to choroid effusion, and which is managed by oral steroid. Then posterior capsule opacification can occur in the late post-operative period, and YAG capsulotomy should be done after 3 months of surgeries. Then you can also have anterior capsule phimosis. Then late in the back dislocation of IOL, weak zonules increase its possibility, and use of CTR reduce the risk. Some surgeons prefer the 3-piece IOL in these cases. Then inflammatory deposit can also occur on IOL. Now the post-operative management. So there have to be the frequent visit, then the normal after cataract surgery. Topical steroid should be given, and the dosing depend on severity of inflammation. It has been recommended that we should start with 6 times a day for 1 week, and then taper weekly. Then topical NSAIDs can be given and continue for 6 to 8 weeks after the surgery. Then cycloplasics, which help to reduce risk of iridocapsular adhesion, can be given. Then oral steroid, which we started on the dose of 1 milligram per kg per day. From first 2 days, it can taper by 10 mg every 2 days. This is the standard tapering. Thank you.
Yes, very good presentation. Can you go back to the this thing preoperative examination slide? So in case of these cataracts, I think she has mentioned already that the prognosis has to be properly explained to the patient, and we have to always assess the potential vision of the patient. For example, if a patient has cataract, but patient has a lot of vitreous haze or posterior uveitis associated, then the chances of vision improvement might be very low. So that has to be properly explained to the patient. Second thing about the pupil management, she has already shown the surgical video. I think sphincterotomy is another way to treat it.
Yes.
Good sized capsular excision is very important because, as she mentioned, anterior capsular phimosis is known, and when it happens, it is very very severe. So many times it may lead to decentration or subluxation of these IOLs. So, and generally we prefer hydrophobic IOLs in the back in these patients. Uh, Sulcus placement preferably to be avoided. But in case we have to place something in the sulcus, then maybe we have to use either three-piece or use a hydrophilic IOL. Now, postoperative already mentioned about the steroids. So generally we give tapering steroids for 3 to 4 weeks in patients who are controlled. Generally, we don't take up patients who have active inflammation in the eye. So we control the inflammation beforehand. The standard time period mentioned is 3 months. So once the inflammation is controlled for 3 months, then we can take up this patient. In rare situations, maybe we may need to take up patient earlier, but the inflammation preferably has to be completely controlled. Okay. Along with this, if there is a chance that patient is going to get recurrent inflammation later, and if required, we can also give posterior subtenon steroid or intravitreal triamcinolone combined with the cataract surgery. Okay. Any questions? And also, we have to keep in mind when operating these patients is that there is a possibility that zonular weakness might be there in these patients because of the persistent inflammation. So that has to be always kept in mind while operating. Most of these patients are having soft cataracts depending on age, but generally these patients are younger in age because this is not age-related cataract, so they have softer cataracts. Any questions from any of them?
No, sir.
Vaishali?
No, sir.
What are the different causes of uveitis in children?
Sir, juvenile idiopathic arthritis, Bessett's disease.
Yes.
VKH.
PKH is rare in children, usually in elderly. Toxoplasmosis can cause inflammation. Sometimes toxocariasis, though we haven't seen very commonly, that can cause inflammation in children.
Yes, sir.
Okay. Post-viral, post-vaccination also, inflammation is known.
Okay. Fuchs heterochromic cyclitis.
Yeah, huge. But of course, not so common in young children, usually happens in young adults. Okay.